It's lovely to be here tonight to talk about telehealth in the disability community. Now, we are particularly blessed today to have Diane from New Zealand Relay Interpreting to provide us with our sign language interpretation. So thank you so much for that. We're going to kick on in, and we're very fortunate to have Prudence Walker, Sue Emirali and Brooke Dibley with us today. And I'm going to get them to introduce themselves just in a minute. Brooke, did you want to introduce yourself, please? You'll have to unmute yourself first, mind you.
Hello, everyone. My name's Brooke Dibley. I'm a speech language therapist based in Pukekohe, and I entered the world of teletherapy about 5 years ago. I specialise in creating digital speech language therapy materials, and I started off that journey with the mindset of reducing the amount of printing, cutting and laminating I do in my therapy sessions, and it grew from there when I realised a huge part of the American teletherapy community were using my resources, and I dived in feet first. It was amazing, and I became, don't quote me on this, but one of the first private therapists to offer full-time teletherapy as a service as a private therapist anyway in this country. And when the lockdowns hit, I was a big part of training the speech therapists here in New Zealand, specifically the private ones, in doing teletherapy so they can still service their caseload despite the lockdown. And I also helped formulate the guidelines for the New Zealand Speech Language Therapist Association around teletherapy and telehealth and how we do that here in this country, because it wasn't really a big thing in my field anyway, in teletherapy, in speech language therapy, before the lockdowns. So that's me.
Awesome. Thank you so much, Brooke. Sue, would you mind introducing yourself?
Yes, absolutely. I'm Sue Emirali. I live on the Kapiti Coast, just north of Wellington, and I'm involved in disability issues at a DHB level, and I'm passionate about being able to make life a lot more accessible for disabled people, especially those in smaller communities. And one of the telehealth wins that I think anyway is my GP. When you phone to make an appointment, you're actually triaged over the phone, so by a GP who's actually living in Japan, believe it or not. So telehealth can work from anywhere, and it actually works brilliantly. I think there was a little bit of pushback initially, but for the likes of myself who doesn't drive, and it's not as easy to get out as it is for other people and actually get to a GP practice, I found it brilliant, absolutely brilliant. So looking forward to the Kōrero tonight.
Great, thanks. Thanks for that, Sue. So my internet's a bit slow, and I'm also making sure that Diane has enough time to share how we're doing. Are we doing okay, Diane? Yeah, awesome. All right. Prudence.
Kia ora koutou, ko Prudence Walker toko ingoa, no Pahia Tua Aho, no Otatahi Kainga and Nainge. So I'm Prudence. I was raised initially in the Wairarapa and then in Taranaki and in North Otago, and I am now living in Otatahi, Christchurch. I'm the Chief Executive of the Disabled Persons Assembly of New Zealand, and also identifying as a disabled person myself. So in my role and as an organisation, we hear many issues from the community and of course ideas for opportunity as well. So telehealth and connectivity in general are some of the issues that we have written submissions about and things like that. And of course the disabled community has a lot of ideas around how, solutions that may work, and also unfortunately experiences a lot of marginalisation, and so we're always striving to achieve equity in that regard. Of course, COVID-19 has seen a lot of opportunities for telehealth. And a lot of, just in general, a lot of ways of, thinking of things differently to perhaps how we have in the past. But it occurred to me, actually, just as we're initially introducing that I haven't had a lot of experiences with telehealth. However, back in 1999, when I was diagnosed with a rare tumour, we actually got a medical opinion from the United States about that, where you actually, paid $100 or something, sent all your scans and everything, and they rang you. So actually, that's my first experience of telehealth, because being a rare tumour, then in New Zealand there wasn't a lot of experience in diagnosing that particular type of tumour, and what they diagnosed over the phone.
I think Prudence might be on rural broadband as well, but isn't that interesting that we've actually had two shares now of that telehealth experience being an overseas experience, so overseas providers providing care in New Zealand. And I wonder, Sue, what your perception is of the care that may be available via telehealth in New Zealand from New Zealanders.
Yeah, Ruth, I really am looking forward to it expanding and becoming a lot more accessible especially for people in rural or smaller districts. I mean, for example, here in Paraparaumu, where it's 100 k's round trip to Wellington Hospital. And for a lot of elderly people or a lot of disabled people, that's just not an option. It's, there is good public transport, but that's also not an option. It's 2 hours each way, train, bus, etc. So it makes it very difficult. And I think it's the way of the future. And I would like to see it become an option where you could actually sit at a local medical centre with a nurse or a nurse practitioner or even the GP, and the specialist talks. You can have a conversation with a specialist who could be based anywhere in the world, really, and your GP be able to make sense, if you like, of what's being said, or explain to you what's being said, rather than this waiting for 3 months, 4 months to see a specialist. I think there's the options are enormous, and it's just a matter of everybody getting their head around that this really is going to be the way of the future.
Yeah, now it's interesting you say that, because I've certainly been at meetings, mostly admittedly within the hospital setting, which will say things like, people who are disabled, people who are blind or deaf, how are they going to use this video thing anyway? But what you're saying is actually there are some big advantages there.
Oh, huge advantages, yes. Because for the likes of myself, sitting looking at a screen is not much use. But being able to hear a voice is the critical thing. And also, as we have here today, I mean, you can have interpreters on one screen relaying whatever the message is. So it works.
Thanks for that. So, Prudence, what about your experience? What do you think about New Zealand practitioners in telehealth? I mean, you've talked about an overseas experience. Are you looking forward to a New Zealand one?
So the thing about telehealth, I guess, is that in technology we have to be flexible, and so my connection dropped out for a bit there. But I've been thinking about this in relation to the health system transformation, and having had a rare disease, there are no specialists in New Zealand on that, and if there was, say I'm living in Christchurch, and say there was somebody who had a lot more experience, or was just better suited to handle my case. I see the real possibility in that, if we can do more of that across the country. So I'm not sure, what that looks like in relation to the health system transformations. But in my mind, my imagination is going, okay, so if we're not restricted by DHBs, that means that somebody with a particular diagnosis potentially could have the best person suited to them in whatever medical profession it is, work with them. And to me, it offers the opportunity for more choice, because while in some situations, being in person may be best, actually, I think disabled people weigh up a lot of things when having to think about, just life in general, but and thinking about their healthcare. So in my situation anyway, I would certainly appreciate being able to choose who I might engage with, or know that I could get the person who was most qualified or experienced for whatever my experience may be, and engage with them. So, I think in the framework of enabling good lives, which is a big thing in the disability sector, and guiding disability support services, I think we'd, as disabled people, really like to see that in terms of health, that we actually had some choices as well, because we don't have equity, and we're our lives are not understood, and then there may be specific health-related things which may or may not be related to our disability, but it just adds on these inequities, and so I think there's really opportunity there. So I hope that in a few years' time we can see that come through.
Yeah, and it's as you say, it's about choice, isn't it? And I think, as we started this webinar, we said that, no one voice can represent, every disabled person in the country. And I think, maybe that choice part is the bit that we may need to push a bit more. So that's interesting that you picked that up. And from the New Zealand telehealth leadership perspective, we've talked for a while about this concept of patient anywhere, specialist elsewhere. So, a clinician with particular skills who can be anywhere in the country, being able to contact that patient, and the whole world, as you say, can potentially open up. But Brooke, I'm interested in your take on the barriers in particular, because you've been working in this for a while. So tell us a bit about that.
Yeah, so this is definitely something that comes up first when you talk to people about teletherapy. My experience in this area has been both with being the person doing I say teletherapy, by the way, because I am a speech therapist, so we say teletherapy, but it means telehealth. I get the barriers from the side of being the therapist that's providing that telehealth, but also from training others and their concerns. So the first thing I would say to any healthcare professional that is very apprehensive about trying this new thing is, yes, there's barriers, but there's barriers to your current model too. So if we're thinking about a client or a patient that is potentially having trouble accessing transport to get there, you've now got a higher rate of do not attends or late comers, and so now your time is pushed again. Whereas if you've taken that barrier away, where now their only need is to attend their session from their home, you've now cut another barrier out. So it all weighs up. Something that comes up a lot is I get asked, Well, what if the internet cuts out? Well, as Prudence just shows us, you come back. And it's no different to what if I'm in a meeting with other healthcare professionals and I get an important phone call. You leave the room and then you come back. Or if I'm driving to a client's house, which is my current model, and I get a flat tire. Well, you deal with it. And so, yes, there's barriers, but I think that COVID-19 has brought about permission for us to be a bit creative and to trust ourselves as individuals beyond what we see as normal, and ask ourselves, how can we better provide equality, equity, and how can we better provide our service to everyone, and that it can benefit us too, not just our patients. It's really mutually beneficial for everyone. I hope that helps.
Excellent. No, thanks, Brooke. And we're getting a few questions through. One of the things I would say is that absolutely anyone on this webinar, if you go to our website, you can sign up to our newsletters. So that's one question there. So how do you keep up to date with telehealth? And it's lovely to see everyone chatting in the chat. Please keep that up. There's quite a few comments also just in regards to sign language, and it never had occurred to me before that overcoming the lag of video with sign language has obviously been important for some. So followed by a comment about how we access interpretation, and I'm not sure whether it would probably seem mean to ask Diane to to answer that as well as interpret. So maybe what we'll do is we'll get that answered later on. But I know that from the New Zealand Telehealth Services that there is access to interpretation through that. So we'll find that answer for you.
Can I just comment on that, Ruth?
Please.
Yeah, without out specifically, I think the issues for deaf people often is that people don't realise how much it takes to organise interpreters to be there at the time that's needed, and there's a severe lack of interpreters as well. And so, you know, if you're thinking about you know, if people are sending out appointments for things, and it may not be a lot of lead-in time, and you need to be able to organise interpreters. So without speaking too much to the real specifics of what is in place and everything, then I think that those are some things to bear in mind. And, you know, for a lot of disabled people, there are additional requirements, like disabled people generally don't appreciate 9 o'clock in the morning appointments because for a lot of disabled people they've already been up for hours and it takes them a lot to get ready and you know, to get out of the house and everything. So I think you know, that it really does offer opportunity, that telehealth.
Yeah, that's a great example, isn't it, of a specialist who could be, you know, everywhere and yet still in one place, as you say. So that specialist interpreter service, which is, you know, so valuable. Yeah. Now, I've got a great question here from Marie, who says, Cura, we have secured funding from MOH to provide telehealth services to primary care to enable equity of access in Hutt Valley. What key messages do you think we need to give primary care to engage them in this format? Oh, that's a great question. Right, let's start with Sue. Key messages to engage primary care.
That's a biggie, isn't it? Initially, it's going to be, you're always going to get people who are up to try new things. that are willing to try new things. Professionals are always, you're always going to get a mixture. They're human like everybody. And I think you work with those that are willing. I know there's been a reasonable amount of telehealth around vaccinations and information sharing. So I'm not quite sure where they're at this, whether initially it's information sharing or whether it is actually telehealth for patient consultation.
I think we can probably assume that or at least what's being discussed at the moment in multiple DHBs is the ability to have a hospital-based specialist talk to a general practitioner specialist with the patient in with the GP. That's certainly a model that's been mooted, and I suspect that that's what this is talking about.
Right. I mean, this has been happening already, especially endocrinology. Have been doing that for years with GPs, the specialists, based in a major hospital with GPs around the country. I know that's been happening for some time, but I don't know. I mean, there's always going to be some restrictions on what's going to work well and what's not. I can't necessarily work out how ophthalmology can quite work with telehealth. But, I'm willing to be proved wrong. I just, also orthopedics, it's the advice can be there, but the one-on-one, I've yet to work that one out.
Yeah, I can answer the ophthalmology one because there are a number of teleophthalmologists around, and what they're doing, of course, is more about the image.
Yeah.
So rather than the video part, if we think about telehealth as being the ability for a clinician to deliver healthcare to the patient when they are, through information communication technology, when they're separated by time or distance. So images are part of that. There's lots of opportunity there. Hey, Prudence, what would sort of advice would you give?
I think I don't quite understand in what regard that is, but just thinking about a few things actually, in regards to being in the Hutt Valley. Of course, in the CCDHB you do have a disability responsiveness team, which I don't believe any other DHB has, so they are a point of contact, and there is disabled people working in that team. And in terms of equity, I mean, I think that you've always got to engage with the community on that as well, and actually have disabled people as part of the conversation. The other things I was just thinking about, the practical side of things. I don't know where a orthopedic surgeon needs to feel your leg or something to see what it's like, but that's where the partnership with like specialist GPs could come in, right? So that there's communication going there, but also I think that the thing for not generalizations, not all disabled people, but a lot of disabled people know far more about their bodies than other people care to know about their bodies, because their bodies have kind of been at the centre of so many conversations for large parts of their life, and so that's where I think partnership comes in as well, and people working together rather than sort of the more dominant and traditional model of the medical practitioner being the one holding all of the knowledge. I'm thinking in my head just through some scenarios, and a previous GP I had who knew nothing about the type of tumour that I had, but I imagine would have been, of course, was a GP, and I imagine would have been very interested had they had the opportunity to be engaged in some conversations further. So that's where, perhaps with a specialist and me, because I've had a lot of GPs tell me that I know more about that than they do, and the GP, it's actually everybody can benefit from something in that partnership model.
Yeah, thanks, Prudence. Brooke, did you have anything to add to that from a clinician side?
A good thing to highlight if we're talking about GP practices is the possibility for more prevention if we're including a specialist potentially earlier because of this model. So I'll just use the example of speech language therapy because it's what I do. For example, some GPs may not know the current recommendations around when is the right time to refer, what is a delay, that kind of thing around, we're talking about children. And so the ability for them to have a speech language therapist consult with their patient in their practice may allow for a less of a gap, because what we can see, if misinformation is given, we see children later and the time it takes to help children catch up is a lot longer. And so those kind of practical gains may be more possible if we have more ready access to that specialist. The other thing I would say is I think that it's very normal and understandable for a practitioner to be worried about a new form of giving their practice, because we worry about the quality of our service. And so hearing stories about how it's working for other people can be the most empowering thing. I noticed that of all the tips and ideas that I could give to other speech therapists, the thing that resonated the most with them is anecdotal me telling them about how things go, what I do when things don't go well, and what I do when things do go well, and the big successes we've had. And the last thing is just reminding them that for many of our patients, it's what they want. We've had both Sue and Prudence mention that they wish there was more access. And so we want to be putting our patients first. And so hopefully that will give them some encouragement.
Put your patients first. It's a very good line. I do like that, Brooke. Now, there's a couple of really great questions in here. One of them is talking about the idea of community health centres, clinics or hubs with added telehealth consultations, and recognising that we have what we call a digital divide, so that not every patient will have access to either a device or bandwidth, for example. What do you think about shared health appointments or shared access to specialist care? So you got any comments on that from your perspective?
I assume when you say shared, you don't mean multiple patients in a room. No, I think, Ruth, that it's a great idea that where you've got a health hub, and I'm really looking forward to this model taking off with the new Health New Zealand system, because once again, we seem to be being pushed into a centralised system for hospitals, and we all know the cost of running a hospital. So there's going to be more and more health centres set up, and I think once again, it's a perfect opportunity where telehealth can be at the centre of it, and not necessarily sitting with GP while you're on telehealth, but maybe a registered nurse, somebody who can make notes, or and whether it's a video call, a phone call, whatever the technology is, that you actually go to a central location to have that consult. I think that could work for a lot of people.
Okay. Prudence?
Yeah, I mean, I think so far as the digital divide, and, you know, some people are just not as technologically minded as others, or that just adds stress to the situation. And I think that we've got to offer options. Like, it's the whole thing of being flexible in that. But I think to make things more generally accessible, we need to think about, you know, video call booths in public libraries, or at your local council, like places that we're going to think about rural communities as well, and actually how do we make it as accessible as possible for everyone, because too, you know, you could be really technologically literate and have all the setup and not personally have the digital divide. But if we're talking about therapy or medical appointments, then you may not have the setting at home, or you might want some privacy. So to be able to have options for people so that they can connect from home, or they can go to one of the really publicly accessible places to access that service.
Brooke, any comment?
I 100% agree. I think it's a fantastic idea. Yeah, these places are already set up with accessibility in mind, and privacy is something that's important. And so if we can have something that's already set up with that purpose, with an easy to use system to help those that struggle with technology, that's linear across the entire country, so when they walk into something like that, they know what to expect when it comes to the technology, I think it would be fantastic. It's like a dream.
Yeah, there's certainly a few comments, you know, about the idea of hubs. So that's good to know. But it does kind of bring us also back to, you know, all our communities are different as well, aren't they? You know, and, you know, within our communities, we've got a diversity on top of that as well. And one of our attendees has asked about engaging disadvantaged communities. You know, we know we don't do this well for multiple reasons, I'm sure, but particularly people, you know, Valerie sort of says, you know, engaging disadvantaged communities who may need a support person or interpreter, so that the right questions are answered. And I also noticed that someone also in the chat commented that allowing enough time for someone to actually say they've got a communication problem. Actually, I didn't understand what you just said, and here's how you can help. So those are two kind of mixed things. But any thoughts about engagement? Sue, I'm going to start with you again.
Yeah, I think you hit the nail on the head when you said about the giving people time. Often people are reluctant to divulge to a new person that they may have a cognitive problem or you know, something that's just it takes some time to get their bearings and to grasp the situation and to be comfortable enough to be listening. And I know in my own situation, I've had quite a few conversations with people about the cost of interpreters where English is a second language, that it's actually imperative that you've got someone there who can interpret, because, you know, they may bring a family member along, but it depends on how engaged that family member is as to whether or not they're stressing the points that need to be stressed or indeed interpreting correctly. And so that's another whole another issue. And you know, we have quite a lot of people in our community that do have English as a second language. So I feel for them. And yes, people with disabilities turning up for appointments sometimes need a little bit of time to, get their breath back, for example, before they can start to even have a conversation.
Yeah, no, very good point. And I think, there's also many of our community who are disabled don't necessarily have an obvious disability either, hey? So maybe being a bit cognizant of that, that's a really good reminder. Thanks, Sue. Prudence, your comments?
Yeah, there's a few things in there. So far as equity for marginalised populations, I think in addition to, the things I talked about in the last question around hubs, actually looking at where people go, so where is going to reach marginalised population groups. Talking with marae and Pacifica communities and churches in those communities, and with rainbow organisations and, all those population groups to go, actually, what's the best way for this community? And, there's not one answer across a whole community, but if we can offer options within that, then we're likely to engage people more. I see the opportunity for interpretive services, whatever language it may be, in terms of telehealth as well, and perhaps a different approach to services, to those interpretive services being taken. Not sure exactly what that looks like, but I see real potential there.
Good points. I must say, in my practice, I use my cell phone a lot to get hold of an interpreter on the phone, and I find that does a couple of things. The one is that it gets somebody there quite promptly, but the other is, for example, in smaller communities, they're not having to confront each other isn't the right word, but just if you know somebody who you're interpreting for, it can be tricky. Yeah. So that can be, and sometimes we forget that actually interpretation over the phone can work pretty well.
Yeah, and I was going to raise that point as well about communities where interpretation is required, and there often being a difficulty in smaller population groups of people knowing each other, and so you don't want to communicate openly because you don't want that person knowing your business. But again, I think it's about choice, because some people may prefer to have a family member, and some people may want a professional interpreter who they don't know at all. And I think that's really where it's important to enable that choice. On choice, I think that really we need to understand more about choice and control and what supported decision making actually means, and not specific supported decision making so far as people with learning disability or anything, although that too, but actually in terms of consent. Like, I went and got my COVID vaccination and they rattle off but kind of dismiss in the process, oh, well, some people get cold and flu-like symptoms, but that only lasts a couple of days. And I'm like, I have cold and flu-like symptoms all the time. And they're like, oh, so do you give me your consent? And I'm like, we haven't actually given me any information, so how can I give my consent? Now, I'm somebody who can present in those situations, and people can't necessarily, or probably often can't tell that I have cognitive impairment, and so processing information and everything might mean that I need longer and things like that, and so I do need more time generally, but I think I've been thinking a lot about, just supported decision making in general for anyone, and I don't know that some people are probably going to object now, but I don't think we do it that well for anyone, because there's limited time for everyone. People care, but they're trying to get through X number of patients in the day, and so they too are pressured for time and the process involved in that. So I think we really need to look at what are the opportunities to really inform choice and control and true consent.
Well, that's a really big one, isn't it? I can feel another webinar coming on about consent, and I entirely agree. And often, and again, I'll come back to my practice. I use Health Navigator a lot, so I will print a whole lot of information, and sometimes, thankfully I've got a little bit older and wiser, but sometimes I will assume that my patient is just as literate as I am, can read all those pages, and it actually wasn't until I had a severely dyslexic man who couldn't fill in his ACC form that I thought, all of these years I've been doing this really badly. Anyway, that was a good lesson, I can tell you. But Brooke.
Okay, so what I would have to say about the consent too, which also ties into what we're talking about with the interpreter, Rachel's raised a good point, is that sometimes using family members as a communicator can pose huge ethical risks for both the client and the practitioner. But then what Prudence said is true when it comes to choice. So I feel like a barrier that needs to be cut down, that I don't know how to fix, is how do we gain that informed consent from our patient for who their interpreter is in the first place? Because if we do not speak the language of that person, and it's something we really need to consider. I have been a big part of my professional life was going to visit people at home, and family would often interpret. It was a choice given to people when we booked their appointments if they'd like a family member to interpret, or if they'd like someone from the DHB. And often the person we're making the appointment with is the person who's going to interpret, so they offer themselves as an option. And I often did think about that, how we get that informed consent for interpreting services. I don't have an answer, but I would like to see a solution there.
Excellent, I think. It's always good to have more questions than answers. Absolutely. And in fact, people might like to throw some stuff in the chat and give us some good ideas. There's a few themes coming through in terms of Māori and Pacific people who are disabled, and we know that if you don't speak English, if you're Māori or Pacific Islands and you're disabled, so if you've got any combination of those, you're at a disadvantage, right? So any thoughts about, and again, because we're talking about telehealth, any thoughts about for our telehealth specific audience, how we might help overcome any of those? That's a bit of a hairy one, isn't it? Sue?
Yeah. It's very hard, isn't it? It's such an individual. When you talk to people with disabilities, it's everybody, as you say, not all disabilities are visual, and people make assumptions. So the doctor will see a diagnosis on a paper, but within a disability, there could be a spectrum a mile wide, and some people will be able to be in control of their own health pathway, and others won't. So it's a very individual journey. It's a very individual journey.
Yeah, so we come back to that, that choices and not making assumptions again, don't we? So really good basic things. So Prudence.
I mean, of course, marginalisations are compounding. So, if you're a Māori person who is disabled and queer, then, you've got all of those marginalisations at play there. I think to that and just in general, the best, it's not a telehealth example, but I've been involved in the COVID response for the disability community, and I've heard lots of feedback about how vaccinations are going around the country for people, and anecdotally, it seems to me that the community has felt that there has been the most success where DHBs have engaged with community to find the solutions. And so I think that's a general principle that we can say that, don't get a token disabled person or a token Māori disabled person, but to truly engage with community and to respect, it's that partnership thing again. I don't think that the wider medical profession needs to come up with all the answers. They've got the expert knowledge in the areas that they've got expert knowledge in. They don't necessarily have expert knowledge in the community. So engage with community to find the solutions, and together you'll be able to get some really good outcomes, I would suspect.
Thanks, Prudence. That's really good advice. And I'm going to morph that a little bit into a more of a topic for Brooke, because there's another comment that's come in just about making sure that we don't further increase inequity and the gap with telehealth. There's a conversation here about framework in the form of reasonable adjustments, which I've never heard of, so I'm gonna have to look that up. Could the New Zealand model of this not potentially fall into a trap where it is best efforts and exacerbating barriers? Brooke.
I 100% agree that we need to be careful that we are not creating a bigger divide, but we cannot just throw the blanket of telehealth over something in a hope to fix everything. It comes back to a person-centered approach. If it's the best approach for your patient, it's the one we should do. And I think we think about that at a medical level. If a person has a certain diagnosis, what is the best treatment possibility? But we need to be more holistic in how we think about this, because beyond that room that you're in, there's how that person gets there, how they access your information, that whole idea of that holistic looking at health, because it's so important. Otherwise, you've wasted your time. And I know that sounds brutal, but if a person leaves your office and they haven't been able to, due to other barriers, hold on to that information that was so important, you've wasted their time and you've wasted your time. And so telehealth is one of the tools we have in our toolbox. And what I advocate for is that people start seeing it as a relevant tool, and that when it is the best for our patients, we use it. Other than that, we really can't assume, because there is a huge equity issue, a digital divide, access to technology, access to high-speed internet. Also remember that telehealth can also just mean the telephone, like that's what it started as. So if your profession allows that, someone was sharing some awesome stuff in the chat about counselling being provided. I'm not sure if it was via the telephone or web services like video calls, but either way, I do know that people have done counselling via the phone for a long time and things like that. Then it's also an option. So, yeah.
Yeah, no, good point. And sometimes actually the phone is preferred for some people, so again, it comes back to choice. And we are unfortunately having a few problems with Zoom, and so we're going to have a very, very cut off at 8. And I'm aware we've only got 7 minutes left. So if we immediately go off air, then you'll know what's happened. Zoom has definitely kicked the bucket. So maybe what we'll do is just finish off. We've talked about how important it is to have choice. We've talked about how important it is not to make assumptions, and we've talked about diversity and inequity. I just want to bring some of those social things back just for a minute and think about, are there opportunities within telehealth to address some social determinants of health along the way? And if so, how would we do that? I know that some of this has been done in Waikato with checklists and check-based systems, but any thoughts about the use of telehealth and social work? Or I'm not phrasing that very well. I'm hoping somebody will save me here.
I think it's already being done in lots of ways, Ruth, with various organisations using telephone trees and, for social wellbeing, connecting people, giving out information. I know there's a really good group that for fibromyalgia that all talk and get together, and they can discuss medications, they can discuss meditation, they can discuss anything, and that's all done. And there is a specialist, a rheumatoid specialist that oversees it. So there's always that medical knowledge there, but it's basically for people to connect, and especially new people, newly diagnosed people. Yeah.
Yeah, thanks, Sue. And certainly some of those, our social networks, as you say, and social media have got a role to play there too, haven't they? Prudence, any comment on my rather convoluted question?
I think, so far as the social determinants of health, there's quite a bit in there, isn't there? But I'm just thinking of the thing that we mentioned before about, what it can take for people to get to wherever an appointment is for them. And then, of course, so I'm thinking at that end about those things that they can get there and they can be in person, but they might have to pay a whole lot in a taxi fare to get there. They might have to really stress about their day. They might have to get up 3 hours earlier, which is not contributing to people's health. And so that's where I see telehealth could play a role, and that actually, and in a holistic sense and economically and, in a whole lot of ways, that actually, I think I might have frozen.
You did. I was just saying jolly rural broadband, but I was on mute, so there you go. It's the choice of Zoom. Gonna love it. Brooke.
I don't have much more to add. I agree.
Oh, that was a little bit soft from you, Brooke. Come on. Usually you've got some really curly ones. Prudence stole all the curly ones today.
I think it just comes back to being holistic, right?
Yeah.
And being patient-centered. Yeah, it really does. And just considering everything else that's happening in a person's life. And also, if you're seeing a high amount of DNAs from people, did not attend, asking a bigger why question than just, 3 do not attend, discharge. We got to look into why.
Yeah, that is a really, really good tip, though. Absolutely, Brooke. We do tend to be a bit early to discharge people, don't we? I agree. Well, look, we've just got a couple of minutes left, and I know that there's lots of comments still going on in the chat there. One that I'm interested in just covering or quickly is, Jackie's popped in. Do I see someone sooner by video, but even if it's a potentially lower quality consult, or shall I wait longer to see them in person? A quick whip around. Sue, is that a yes, no, maybe with a caveat?
Yes, no, maybe, Ruth. I think it's very individual.
So dependent on the patient, comes back to choice again. Prudence.
Yes.
Yeah, absolutely. It's a conversation with the patient.
Let them make that informed choice. Yeah.
And that's where it comes back to consent.
Together. Yeah.
Yeah, totally. Isn't that great? So that wraps it up nicely. So, consent. Does the patient understand what they are consenting for in a telehealth appointment as well, I think is important.
And also it might not be lower quality, depends on your profession, but we always assume it's going to be, but I found it's not for my profession anyway.
Yeah, nice comments. So before we get cut off at the knees, I am going to thank Diane again. I think we've tired her out. I'm sure she'll need a good rest from the New Zealand relay interpretation. Thank you so much, Diane. Sue, thank you very much for sharing your time with us. It is very much appreciated. Prudence, again, thank you very much. And Brooke, unfortunately, Mary, I don't know what's happened to Mary, because that would have been fantastic to have her. And judging by the number of people we had on the line, I suspect we might just have to do this again with some more bodies. Hey, all right. Okay, all right, well, that's it for us. And we'll see some folk maybe in another month for another telehealth webinar. All right, okay. Ka kite.